new voices in global health. I think this gives this meeting a slightly different sort of aspect. It gives it sort of the kick of what is really happening on the ground. And it brings you, young people, to the forefront who do actually do research in this area. And I think that is, so important. And you'll be the future leaders in this field of global health. So I'm really, really grateful that we always get such a good response. We had, again, over 120 abstracts submitted to our call, and you are one of those who've been selected. So we've selected, in the end, 18 abstracts, 5 for oral presentation, which is tomorrow afternoon at 4:30 to 6, and I hope that you all come to that as well. And then the ones that we're discussing today and tomorrow during lunchtime are the posters that are all at the back of the Weltsaal at the end of the conference venue here. But let's just start with the first presentation here, and I'll just invite Sarah to come. Sarah is from Columbia University, and she will talk about the legal and medical basis for granting asylum to women with female genital mutilation in the US. A very, very important subject. Sarah, please.
You can send me here or there, whatever you like.
Zu spät, jetzt machst du den nächsten, dann kannst du ja mehr erzählen.
Maybe I'll sit, because that's fun.
Brauchen wir nicht so viel.
You have to press that button.
Okay. Oh, there we go. Okay. So in order to understand the problem about whether or not to grant asylum to women who have already undergone female genital mutilation, which I'll be referring to as FGM, in the US, we have to have some understanding of the Immigration and Nationality Act. This is the basis for asylum in the US. And under this law, it's necessary that someone who's applying for asylum has to have a fear of future persecution. And the reasons for the persecution must be based on race, religion, nationality, membership in a particular social group, or political opinion. So the case law surrounding FGM and asylum in the US really starts most significantly in 1996. There was a case called In re Kasinga, in which the Federal Board of Immigration Appeals tried an asylum applicant who was a 19-year-old from Togo. She had been prevented from undergoing FGM because her influential father had protected her. Sure, but I have this, yeah. I just... It's okay.
And show now, the show has to begin. So, previous and previous. Okay.
That's okay. Okay, so in re Kazinga, the asylum applicant was a 19-year-old woman from Togo, and she had not undergone FGM because her influential father had protected her. But when he died, she fled Togo, and because other family members were threatening to have her undergo the procedure. And she was granted asylum, and this was sort of a basis for the idea that if a woman fears that she will undergo FGM, then that's a good basis for asylum in the US. But then the question started arising, what if a woman has already undergone FGM? And so in 2004, there was a case, Mohammed v. Gonzalez, and the US Court of Appeals held that women who have undergone FGM in the past should be eligible for asylum even without proving fear of future persecution. And the basis of this decision was actually because FGM should be considered a permanent and continuing act of persecution. So in essence, you are fearing a form of future persecution. But other courts disagreed with this judgment, and there's still a lot of debate. And to argue for the idea that past FGM should be a basis for asylum, some have said that it's an ongoing process, as in the Mohammed v. Gonzalez case. and it continues to inflict consequences. And others have said it should be considered part of an interconnected set of persecutions that revolve around the identity of the person persecuted, i.e. being female. So you can see a little bit about my methods as a systematic review. I went through Hein Online for legal articles and PubMed for medical articles. And I just want to point out that, I ended up with 35 articles. I initially found over 1,000. What's interesting is that there are a lot more legal articles than medical articles on the issue. And so even at the end of my analysis, there was a sort of weighted toward the legal side. And I just wanted to briefly mention the physical effects of FGM because I think it's important to know that there are long-term effects in addition to short-term effects. And these are pretty well established. Women who have undergone FGM have more complications in terms of perinatal tears, bleeding, incontinence. And there are also serious consequences in childbirth. There's also some data, although it's limited, on the possibility that FGM can increase HIV transmission. And there is some biological plausibility in suggesting that FGM may be associated with increasing prevalence of HIV in sub-Saharan Africa. So clearly an important issue. And of course, there are short-term health consequences, which include shock, excessive bleeding, infections. But I wanted to focus a little bit more on the psychological effects of FGM because I think that's more relevant to the issue of asylum. This is not as studied, and I think that there's a gap in the literature here. But in one study over a 4-year period of 1,824 women who underwent FGM, 80% continued to have flashbacks to the FGM event. 58% had an affective disorder. 38% had anxiety disorders, and 30% had post-traumatic stress disorder. In another study among 23 Senegalese women who underwent FGM, they reported a significantly higher prevalence of PTSD and other psychiatric problems compared to uncircumcised controls. And it's pretty well established that many infibulated women have chronic anxiety and depression, and this probably is partly arising from worry over their genitals, intractable dysmenorrhea, and fear of infertility. So this brings me very quickly to my conclusions. So basically the point that I was trying to make is that that medical professionals have an obligation, I think, to be more involved in this debate and discussion. And some reasons for this, there's a surgical procedure, de-infibulation, which is performed in the US, and it can reverse some of the anatomical damage that's done by FGM. But women are, first of all, usually obviously unable to access this potentially life-saving procedure in their home countries. And if they're de-infibulated in the US and then they return to their countries, they face ostracism, stigmatization, discrimination, and also re-infibulation. So basically, there can be a fear that this persecution can recur. And also, on the psychological side, as I mentioned, women who have undergone FGM have elevated rates of PTSD and flashbacks. And a hallmark of PTSD is pathological re-experiencing of the original trauma. And so returning a woman to the scene of the original trauma engenders substantial risk of worsening trauma-related psychiatric illness. And in addition, the treatment for these illnesses is not as readily available. And so in conclusion, I just wanted to say that there's strong medical evidence that health professionals have an obligation to be more involved in this debate. Thank you.
Thank you very much, Sarah. A really, really, really important topic. So we have time for 1 or 2 questions. Could you come to the microphone or shout? Yes, you can shout, actually.
Hi, I was just wondering how many studies there were, how many legal cases there were, how many got accepted, and how many got rejected?
Oh, in my analysis?
Or generally, in the history of the cases.
Oh, okay. I don't know how many in the US there are. I mean, there were 3 very important ones, 2 in both in the 90s, and then this one in 2004 or 2005. But it's not, in general, it's not that common to see that many legal arguments about this particular issue, but I think it's becoming a little bit more common because now there's an argument that women who come to the US with their daughters are concerned that if they're returned, that their daughters will undergo FGM. So there's a whole nother debate around whether that's kind of legitimate grounds for asylum. But it's not like it's happening every day, but it's relevant or prevalent enough to be talked about extensively in the legal literature.
Yeah, because I was just wondering if the immigration departments were concerned, because if you set legal precedent that it would allow women from certain countries to have potentially a way into a country which, and that the immigration department may be quite against doing that for that particular reason.
Right, that there would be too many, yeah. That's definitely a concern, obviously.
Yes. Yeah.
It's a very nice study. Given that it's a systematic review, I guess, and the cabinet obviously will have a lot of articles for you to have a look at. So the little review was very nice. I was just wondering, in terms of your coding of the articles, I mean, how many people coded it?
How many what?
I mean, how many researchers coded it? Was it by one person or two people? And did you try to verify whether you were coding it right? I mean, because when you have your definitions, you see which one which aspect qualify, which aspect you're looking at. And I was just wondering how many people were involved in the method aspect of the analysis of the articles.
It was just me. What I did was I ended up, obviously you could see I said I started with over 1,000, I ended up with 35. And I was very stringent in my exclusions. I excluded anything there were a lot of articles that had to do with attitudes of healthcare providers and women about FGM, and so I excluded those. There were a lot of articles that were giving sort of practical advice to healthcare providers in Western countries about how to deal with it when they're faced with FGM. I excluded those. I was only limited to the US and only to information about women who have already undergone FGM in the legal articles. So that's kind of how I whittled it down.
Thank you very much, Sarah. That's great. Thank you.
Okay, it's an honor to introduce the next speaker, Ms. Antena Asefa. Are you here? Please come forward. Antena is from Ethiopia. He has a Bachelor of Science from the Bachelor of Science in Nursing from Havasa University and a Master of Public Health from Addis Ababa University. And he's also, quite interesting, a maternal health young champion of Harvard University. So welcome, Antena, please.
Okay, thank you. I'm going to present a research which was carried out in southern Ethiopia and which was targeted at assessing why mothers are not coming to deliver at health institution. So, can we have the presentation there, the slides? Okay. So the title is Use of Institutional Delivery Services in Southern Nations, Nationalities and Peoples Region Ethiopia. It was a cross-sectional comparative type of study. This research was carried out by a financial support from Save the Children International in collaboration with SNNP Regional Health Bureau. To give you clear insight on the background factors, maternal mortality is still very high in Ethiopia. Among 100,000 live births, it is calculated to be 676 according to the Ethiopian Demographic and Health Survey 2011. And there is also a clear mismatch between the antenatal care attendance and institutional delivery. Only 34% of mothers seek antenatal care from skilled provider. And at the same time, not more than 10% of mothers deliver at health institution. So this shows that still mothers who are seeking antenatal care are delivering at home or somewhere else. Basically, with traditional birth attendants. So we have used a community-based cross-sectional study. Our respondents were mothers who have had delivery within the first 12 months preceding the survey. And we have tried to compartmentalize the respondents based on their geographical and residential area. We have classified into urban and rural. And further, in rural parts, there are agrarian communities and there are pastoral communities who are moving from place to place with their animals. So we have used this comparative cross-sectional type of study using a 95% confidence interval and proportion of births at urban center taken as 6% and rural parts as 2%. And finally, we have got around 2,897 mothers who were interviewed. So we have used female data collectors who are health professionals for data collection so as to minimize bias which may arise during data collection. And after collection, we have entered the data into EPinfo version 3.51, and all analysis were carried out using the SPSS software. In addition to this, to complement the findings and triangulate with qualitative studies, we have conducted focus group discussions with mothers who have had deliveries in the due period, and we have used NVivo version 10 for identifying thematic areas and run out the qualitative study. So coming to the findings, the result revealed that 30.2% of mothers delivered at health institution. There might be some bias. You know that when clients are asked such kinds of questions, they used to, or they incline to respond to what is desirable. And it might be even less than this one, as far as we have the concern. When we see the stratification in urban centers, 82.1 mothers delivered at health institution. In rural pastoral areas, only 4.3%, and in rural agrarian areas, about 20% of mothers deliver at health institution. So when we try to identify factors which affect place of delivery of respondents, as you can see, and you can read from the abstract book, there are variables. For example, household financial decision maker. Those families where there is a financial decision making by agreement with male partner, that showed statistically positive association with institutional delivery. So those mothers who are deciding with their male partner are more prone to deliver at health institution. Those mothers who seek antenatal care from skilled providers also are more likely to use institutional delivery service. Knowledge on danger signs, and at the same time habitual characteristics. We have tried to ask mothers their reason for non-institutional delivery or home delivery. The most reason which was cited by respondents was having previous normal home delivery which was previously occurred at home and where there was no complication. Nighttime labor, and another factors also lack of access to transport and financial protection. These were reported to be reasons for institutional delivery. So based on all those findings, what we can explain is that institutional delivery rate is still very low, and mothers are delivering at home and sometimes attended by traditional birth attendants. But there are mothers who used to say that we were assisted by health extension worker. According to the Ethiopian Primary Health Care Unit, there is a so-called health post. Each health post is serving a catchment population of 5,000, and there are 2 female health extension workers there. They usually take a 1-year training on basic health promotive, disease preventive, and sometimes curative services. So what mothers do is that they call the health extension worker when labor status. They don't want to go to health institution. So this is their main reason, which is being cited. And we have also tried to address the skill gap, to assess the skill gap with health extension workers. And almost 98% of them reported that they didn't ever conduct delivery at health post because it's not convenient. There is a skill gap. There is also a supply side factor with regards to health facility, preparedness of health facility to provide clean and safe delivery. So there is still a huge gap in terms of this service. So we recommend that there is a need for concerted effort to attract women to health facility. At least there is a need for convincing mothers who are seeking at health institution to deliver at health facility, at least to minimize the mismatch between ANC and institutional delivery. This is why we have not seen any improvement with regards to maternal mortality from 2005 to 2011. So this is going to be my final idea. Thank you for. Yeah.
Thank you very much. There's one question. It has to be very quick because, unfortunately, we have to be out of here by 1. So we need to, sort of stick to our time if we can. But one question I'll allow.
What percentage of women reported that transport was a major problem? Because in India, that has turned out to be a major problem, and we've really recently introduced the National Ambulance Service that allows for free delivery for women. So could you sort of...
According to our study, around 16.8% of women reported lack of transportation. Here the government is now this time assigning 1 ambulance for 1 district. In that district there are more than, even in some cases, more than 100,000 population. So still there is a problem. So there is an ambulance, there is a problem in accessing the woman at home. There is a poor facility in terms of the transport access and road facilities also. Yeah.
Great, thank you very much. Excellent, thank you. So I would like to now invite our third speaker, that's Esther Atokunda, please. Esther is a PhD researcher from Mbarara University of Science and Technology in Uganda, and she also has an MSc in Public Health from Leeds University. Esther, please.
Yeah, I'm going to present just a short synopsis of this study that was done between 2010 and 2013. Just to give you a short background of Uganda has one of the highest maternal mortality rate at 338, and that was documented in 2006, but it has been increasing with the recent report in 2011. It has slightly increased to 438. So Uganda, for the first time, registered Misoprostol for PPH prevention in 2008 in a way to reduce maternal mortality, and launched a Misoprostol Rollout program in 2009 to help curb the annoying maternal mortality rate in Uganda. And this was before it was added to the World Health Organization Essential Medicines list, but also to Uganda Essential Medicines list. So in this particular study, we assessed the Misoprostol rollout program in Uganda, and probably have a few lessons to learn. We did interviews, key informant interviews with 82 participants. We did procurement data from health centers up to the lowest health center possible, and we reviewed documents from Ministry of Health, WHO, but also registration dossiers that were submitted to the National Drug Authority and Ministry of Health. And this was all in themes of documenting the registration, distribution, treatment guidelines, and the way it was really introduced in Uganda. Oops. This. Okay. I'll run to a few results and findings. In 2009, I've already talked about how it was registered, piloted in districts of Uganda by those civil society organizations. And in 2009, a massive rollout was done, and there was no evaluation of the pilot project. And we have the training of trainers ahead of the program launch, which was widely supported by the civil society organization as well. In 2010, 2 years after its registration, its distribution started widely in the public health center and also in the private health center by PACE, which is an affiliate of Population Service International in Uganda. In 2011, we have it distributed to all private health centers in Uganda, supported by Misoprostol International, and we have the Misoprostol being involved, part of the mama kit or delivery kit, which is pushed up to the lowest health center possible in Uganda. And this was supported by Genuity Health Projects, University of Liverpool, Makerere University, and PACE. In 2012, this is about 4 years after its registration and about 2 years after it had been distributed, we see the ministry coming to design Uganda clinical guidelines, which are currently still unpublished, and they're not accessible in the health centers to facilitate usage. We also see it being added in Uganda essential medicines list. But notably for the Uganda clinical guidelines, which was formulated and drafted by the Ministry of Health, we see Misoprostol being added as for treatment of PPH and management of post-abortion care, unless the PPH prevention for which it was registered for. And both these documents were supported by, funded by SURE project, which is a USAID project. So we see the different various civil society organizations promoting the rollout program, even when it was not added to the essential medicines list, or the treatment guidelines were not out there, or there was been more training whatsoever, despite the contested evidence in its role in management of PPH. So in all this, the timing, we see it being pushed, widely pushed and actively pushed to the lowest health centers possible, even for those who have refrigeration, where there is no reason whatsoever for the choice, instead of the first line oxytocin, 2 years before its addition to essential medicines list and the availability of the clinical guidelines. We noted that the evidence-based requirements for the registration of Misoprostol, according to the documents that we could analyze, the guideline development and addition to essential medicines of list were scarce. They were actually hardly there. They were widely omitted. And as I earlier mentioned, despite its registration for PPH prevention, it's being used widely for off-label uses, even with no availability of treatment guidelines. So we think the civil society accelerated the Misoprostol rollout program in Uganda ahead of its addition to essential medicines list, but also ahead of its availability of treatment guidelines and proper training on its use. And despite its earlier introduction of Misoprostol as a second-line treatment in management of postpartum hemorrhage, the evidence that's out there in the field suggests that there is an increasing trend of Misoprostol procurement, even by the government or private health centers, over the medicine of choice, oxytocin, which poses great concern in the management and big ramification for maternal health care, which needs urgent evaluation. Thank you very much.
Thank you very much. Again, we have time for one question.
Okay, I would suggest we call in the last speaker of this poster session, which is Ms. Salima Bhatia from India. Salima has a Bachelor of Homeopathic Medicine and Surgery, as well as a Master of Health Administration, and presently she's a consultant in policy and planning at the National Rural Health Mission at the Ministry of Health and Family Welfare of the Government of India, and she will present her poster about the impact of bottom-up planning and flexible funding, the case of National Rural Health Mission in India. Namaste.
Just to give you an idea of what NRHM is, Government of India launched a flagship program called as the National Rural Health Mission in 2005. And the reason they launched it is because before that, we were largely focused on vertical programs. So we had one RCH program, we had one disease control program, we had one malaria program, and they're all in bits and pieces. What we tried to do was, we got them all together under one umbrella. And in India, the central government generally funded only health programs, whereas the state governments were the ones who were responsible for providing healthcare to people. So the central government came in and identified that there is a gap in the rural areas and then moved forward to actually address these gaps with the help of National Rural Health Mission. Now, what is actually important about this particular program, is this right? No. Yeah. Okay. So the NRHM essentially focuses on three things. One is bottom-up planning. We give states a resource envelope. We tell them that this is your pool, and you can plan for yourselves what you want to do. It's like giving a donor funding to a area and telling them this is the area, this is the place, and you can plan the way you want to. Second important thing is there's flexible funding. So they can plan for whatever areas that they want to. Like you have some priority areas identified, but what exactly you want to plan for is up to you. And you also have this entire new gamut or new paradigm of community involvement. I'll speak about it a little later. So my objective of my study was to actually see whether the NRHM has brought in any improvement in health services and health outcomes in the rural areas of the country. I have focused on 8 states, which are the most backward states in the country, to get a good idea of what has happened. Right. If you look at this, we essentially have 4 paradigms with the help of, under the umbrella of decentralized planning. When I say decentralized planning, it means that we give a basic guideline to a state and say, you have to plan for RCH, you have to plan for disease control, but how much you put for each of these is up to you. Up till then, we decided from the national level that there would be, say, 1 doctor per PHC. But it's now up to the states to actually decide how many doctors do they want, how many nurses do they want, depending on their caseload and their availability. The second point is that we focused on health system strengthening. When we say health system strengthening, what I mean is that we allowed them to go in for mobile medical units, for ambulance services, for infrastructure, for human resources, and a gamut of services that fall under the health system strengthening. Now, that's the first time that anybody is speaking of system strengthening. The minister from Ghana was speaking about, supply chain management. And this is what we are exactly saying, that when we allow states to plan, they plan for supply chain management. The next portion was the flexible financing, which essentially means that you're allowed to bring in innovations. For example, a state in India called Maharashtra has a lot of sickle cell disease, and they would plan for sickle cell anemia. A state in the south, which is very progressive, has non-communicable diseases, and they plan for addressing of non-communicable diseases. So that kind of flexibility is allowed under the mission. Community involvement, this is one of the cornerstones of the mission, and we have actually brought in 0.8 million health workers, community health volunteers. They're called ASHAs in India. And for every 1,000 population, we have 1 ASHA who is sort of trained to motivate people to go in for institutional deliveries. For example, when I was talking about what India has done is we have brought in a conditional cash transfer scheme in which we give women coming to the institutions to deliver some kind of monetary compensation. Now, what that helps in is that if they have any kind of transport costs, then that is taken care of. If there are any other out-of-pocket expenditures, that is taken care of, and that helps in promotion of institutional delivery. Let me look at the results. What I found was, while the physical infrastructure, that is the number of health facilities, didn't really grow too much under the mission, what it essentially did was that it brought in a phenomenal increase in the number of nursing staff and the number of ANMs, which are the actual providers in the country. So we have like a 50% increase in the availability of nursing staff and a 30% increase in the availability of ANMs. The second most important thing is that our institutional deliveries jumped from around 23-24% to 50%. Now, that's like a 110% jump if you look at it. That, one of the major reasons for that is the introduction of the Janni Shishu Yojana, because that is what I said, that when you give conditional cash transfer along with health system strengthening. Outcome-wise, we have seen an increase in the pace of decline. So when our infant mortality rate was declining at, say, 14.6% during 2001 to 6, after the introduction of NRHM, we have a 20.9% decline, which is like a 43% increase in the pace of decline. Similarly, our total fertility rate, the pace of decline of TFR has also increased by 39%. And what I essentially want to say is that allowing people to plan for themselves within a particular, within a given resource envelope can act as an important model for people to really bring in health system improvements. The last quote that I have from the father of my nation is of special importance to us because that is what the mission really works on. It's a part of our administrative approvals and we essentially work on this faith. Thank you.
We have probably time for one last question for this session. Anyone? There we go.
It sounds fantastic, but I was just wondering if there are any problems during the handover period and what accountability mechanisms there were to try and rectify.
Right. Problems during the handover period were immense because initially when we actually gave states the ability to spend, they were not able to utilize their funding. So maybe 20%, 30% is what they utilized in the initial years. But now they have states have come to 80-85% of utilization of their funds, which basically means that their capacity to plan and think about what they want is growing clearly. And today they're very clear on what they want. I mean, when they come for meetings, they tell you that this is the plan that I want to go for, and this is not what I want to go for. You cannot dictate to them. They know what they want. That's very important. And accountability, yes. What we've brought in is community monitoring, wherein we involve NGOs, civil societies, and the community leaders in monitoring the health system. But yes, I would definitely say that that's one of the weak areas. And we have introduced very recently an incentive-based or a performance-based financing, wherein 20% of the funds or 10% of the funds are based on the performance of the state on a few parameters that have been identified. So I think that's...
Thank you very much. That's great. And I want to thank you all for coming to this session. I think we have heard some really interesting examples of highlighting where things go slightly wrong, highlighting what can be done to perhaps start with solutions to those issues, and also highlighting that we in the developed world, we have to think very carefully about some of the problems that Sarah has highlighted. I think these are the examples that we need to underpin what we are discussing here at the World Health Summit. So I'm really grateful to you all for coming to Berlin, for submitting these abstracts to us, and for presenting them here in this group today. Thank you very much.
Thank you, and if I may, I would really like to thank both of you for helping us come here and encouraging us so much. It makes a huge difference to us. Thank you.
Thank you.